Hello and welcome to Liquid Gold, Unlocking the Power of PRP. In this episode, our host, Dr. Jeffrey Piccirillo, will review the science of PRP, why platelet count really counts. If you have any comments regarding the content of this podcast or any suggestions for upcoming podcasts, feel free to reach out to our host at realliquidgold@gmail.com.
Hello, everyone, and welcome to the second episode of Liquid Gold, Unlocking the Power of PRP. In this episode, I am going to talk about the science of PRP and why I feel platelet count really counts. Now, I know many of you think of me as a purist. My background is orthopedics, so I always strive to have the best quality PRP. I look at things like platelet count. I look at things we can change both before and after the injection to make sure that we have the best possible outcome. Everything that we do at my practice is science-based. We manipulate the science to push the envelope and make sure that the PRP we inject is the best quality PRP. We look at the process, we look at the platelet count, we look at things like anti-inflammatory medications, we look at a patient's diabetes status and his blood sugars and whether his A1C is stable. But these are all things that play into the equation to make sure that we get the best quality outcome. Now, I've had arguments with other physicians on the regenerative platform. I've even had arguments with my good friend, Dr. Charles Runnels. Dr. Runnels feels that if you have good tissue with a good blood supply, then maybe you do not need as high of a platelet count. He has even been quoted as saying that he could do a O shot with whole blood and still get a good result. And I think that may be possible. He uses the example of a surgical incision. If you make a surgical incision on the abdomen for something like a hysterectomy, you do not need to inject the edges with PRP to get that incision to heal. It will heal on its own because the tissue has great blood supply. But look at some tissues that have much less of a blood supply. Look at things like meniscal cartilage or ligaments or tendons. All have very little blood supply. If you cut through a piece of meniscal cartilage, especially on the peripheral edge, you get almost no bleeding. Articular cartilage has no blood supply. It's completely dependent on the joint fluid to feed the cartilage and to allow that cartilage to be viable. Now, here's where PRP comes in. If we do a PRP injection, I strive to have the highest possible platelet count in the PRP, and I strive to make sure that every variable is controlled to get the best possible outcome. So I'm striving for good outcomes. Now, I feel that whether I'm injecting the anterior vaginal wall for urinary stress incontinence, the penis for erectile dysfunction, the face to control fine lines and wrinkles, or I'm injecting the knee for arthritis, the shoulder for rotator cuff tendonitis, I want the best quality PRP, and I strive to get the best possible outcome. And I hope that you're doing that as well. Now, let's look a little bit about the science and about how PRP actually works. I think you'll find it hard to believe that when we inject PRP anywhere in the body, the platelets that we're injecting really do almost nothing locally. They depend on something called a paracrine cascade reaction. Now, what is that, you might ask? That is a series of events, and I always look at dominoes. I liken it to playing as a kid, setting dominoes up in a row as a child, hitting the first domino, and watching the dominoes fall down the line. And the same thing happens in PRP. This is what happens in a typical PRP injection. What happens is we inject the PRP, and the PRP then breaks open. Kyle, I'm going back. Let me do that segment over again. This is what happens in a typical PRP reaction. Let me do it again. This is what happens in a typical PRP injection. After we recover the blood, we process the PRP. I'm still going to do it one more time. This is what happens in a typical PRP injection. Once the blood is processed and we have the injectable PRP, we inject that PRP through a small bore needle. The small bore needle will activate the PRP, and it will allow the PRP's contents, the platelets' contents, what are called the alpha granules, to break open and to release their content. Those alpha granules are full of cytokines and growth factors. Those cytokines and growth factors now act on the local tissue. They will find tissue that is damaged. They will have binding to a receptor site. And then the tissue itself will release its own cytokines, growth factors, and signaling molecules, which will signal the bone marrow to release stem cells. This release of stem cells is what is called margination. So once we marginate stem cells and we send the stem cells into the peripheral circulation, those stem cells will track back to the area. And it is those stem cells that actually cause the tissue regrowth and the regeneration and revitalization of the tissue that's in question. This can be tissue in the anterior vaginal wall. It can be blood vessels in the penis. It can be articular cartilage in the knee. One of the cytokines and growth factors that's very, very important in this whole paracrine cascade reaction is what's called VEGF, or vascular endothelial growth factor. Now, exactly what does it say? Vascular endothelial growth factor. So it's growth factor that is going to cause new blood vessels to form. It's going to cause what is referred to as angiogenesis. Now, think how important that would be in the penis. New blood vessels to supply the corpus cavernosa with more blood and cause stiffer, longer acting erections. Exactly what our outcome is. Same thing in the joint. If we're trying to stimulate blood growth and stimulate healing into a piece of meniscal cartilage, we want more blood flow to that cartilage. So when we inject PRP, the platelets lyse, the vascular endothelial growth factor goes to that tissue, causes new blood vessel to go to the cartilage, and the cartilage gets healing from the stem cells. This is how that reaction works. So it's important, at least in my mind, to have the highest amount of platelets injected into the area at that time. We are depending on that cascade to do its job. Now, when we process PRP, it's the same way every time. We actually, in our office, will obtain a platelet count the week of the injection. It will give us our guideline of where to start our calculations for the amount of PRP that we are going to inject. We strive for the same thing they strive for in orthopedics every single time, whether it's an orthopedic injection, a sexual health injection, or an aesthetics injection. We strive to have at least 1.5 billion platelets for every cc that we inject. I think that's very, very important, because that way we know we're getting the highest amount of growth factors and cytokines and the highest activity of regeneration and regrowth at the tissue level. So how do we come about that? Well, if we know the normal platelet count is somewhere between 150,000 and 450,000, we use the number that we get back from the lab as our starting point. So for this demonstration, let's use the number 300,000. So remember back to medical school, 300,000 is 300,000 platelets per microliter. But are we drawing blood in microliters? No, we're drawing blood in milliliters. So microliters to milliliters is 10 to the third. So that would actually calculate out to 300 million platelets per milliliter. Now, if we're using a 30 cc kit, and the centrifuge that I use is the Pure Spin from Refine. So they have 30 cc kits, 60 cc kits, and 120 cc kits. So if we're using a 30 and we have a platelet count of 300,000, 30 times that 300,000 gives us about 9 billion platelets. Now, if we know that the recovery rate on that centrifuge is about 80%. It means we're going to lose about 1.8 billion platelets. So that brings us down to 7.2. And if we're injecting 5 cc's of PRP into a knee, into a shoulder, into the anterior vaginal wall as part of an O shot, then if we divide the 7.2 billion platelets by 5, we are actually getting about 1.5 billion platelets per cc. We're right at the level that we want to be for a PRP injection. So that's why I feel that the science is important in getting the best possible outcomes. I'll tell you a story. We had a physician in South Florida. He was associated with the University of Miami, and he was a gynecologic oncologist. He was interested in doing the O shot on women that just had reconstructive surgery of the pelvis after having a tumor resected. And I thought it was a great idea. And he was talking to me about the science and making sure that everything went right. And we were talking about the centrifuge and how to get the highest possible recovery of platelets and the highest possible platelet count per cc of injectable PRP. And he understood the science. It was all good. But the hospital had a contract with another company, and they wanted to go with a single spin centrifuge. And the discussion that we ended up having was he had no idea what the starting platelet count was for his patients, for his demographic. He was dealing with women that had cancer and were going through chemotherapy. So that platelet count could be very, very low because of the chemotherapy. He's not getting enough to inject into the area that he's trying to revitalize and regenerate, and he's not likely to have a good outcome. They ended up going with the cheaper, less expensive centrifuge initially. And then he had a couple outcomes that he did not see the improvement that he wanted to see. And then he finally talked his hospital into going with a double spin process centrifuge and started seeing better outcomes. So it's just proof that platelet count does affect the outcome, especially if you're dealing with a low platelet count. We need those high volumes of blood and high concentration of a double spin system. The other thing is that we need to make sure that we're doing nothing to block the cascade. Now, once again, in our practice, we are very strict. I make sure that the patients are off of all anti-inflammatory medications, including the natural anti-inflammatories, things like turmeric, curcumin, fish oil, because because those medications, as well as the prescription NSAIDs, will block that paracrine cascade reaction. It's like going back to the dominoes. Remember, the dominoes are all stacked up. You hit one and they start falling. Well, if you stick your hand between two of the dominoes, then that cascade stops. And that's what the anti-inflammatory medications, both natural and prescription, will do to the cascade. So it's important to take things like that into effect. Diabetics, the same thing. We know that unstable diabetic, someone that does not have a hemoglobin A1C under, say, 6.5, we know that their stem cell reaction is going to be lessened. They're not going to have that very vibrant release of stem cells from the bone marrow. So it's important to look at the diabetic state and diabetic patient to see if their diabetes is stable or not. Once again, it's something that can affect your outcome. And then we feel it's important to do that calculation on every patient every single time. The other study that I've been looking at, there's two studies I think that come to mind, and I'm going to go ahead and put the links to both of those studies at the end of the podcast. The one study talks about platelet count in orthopedics for arthritis of the knee. And what they found out that they were injecting 10 billion platelets. And at 10 billion platelets, they found that PRP was what they referred to as chondroprotective. That means if they looked at an MRI today and they looked at an MRI in a year, there was no change in the thickness of the cartilage at the end of the femur or at the top of the tibia. There was no additional cartilage loss in a full year with patients with osteoarthritis that underwent this highly concentrated PRP. The other study I've been looking at is a study that was done by Chris Santino at Regenix. And his study looked at what happens to these receptors with age. And we talked about nothing really happens locally. The platelets really do not regenerate tissue at the level. We depend on the body's margination of stem cells to track back to the area, and the stem cells are what causes the regeneration. But that growth factors and cytokines and signaling molecules need to bind to the receptors at the tissue level. And as we age, those receptors go down. So what does that mean? That means is if the receptors go down as we age, we want to increase our PRP dose even more as people age, because we want to make sure that every single receptor is hit with a growth factor and cytokine to bind there and cause the most robust cascade reaction. So his theory is, and I completely agree with him, if you're dealing with a 25 or 35-year-old and you use a lower concentration of PRP, say you do a 20 cc kit and you pull off 5 cc's, so you're about 4 times concentration, that may work in a 25 to 35-year-old. But if you get up to, say, 35 to 55, now you may want to have, say, a 30 cc kit and bring it down to 5 cc's, where you're 6 times concentration. And say, what if you're a 55 to 75-year-old? Then maybe what you need to do is you maybe need to use a 60 cc kit to go down to that 5 cc's, where you're 12 times concentration. So age probably does make a difference. And like I said, I will attach that article to the end of the podcast because I think it's very, very interesting reading. Now I'm going to end today with a story that just happened in our office last weekend. We have a pain management physician that flies in from Iowa once a year to do spine injections. And we had a gentleman that we had been seeing, and we had been getting him ready. He was off of his anti-inflammatories. We were doing acoustic wave therapy to help some inflammation and help build up some vascular endothelial growth factor at the tissue level. He was getting treatments twice a week for about a month, and he was all ready to undergo his injection. So 2 days before the injection, we redrew his labs, and we got a platelet count. His platelet count wasn't 300,000. His platelet count was 186,000. So what does that mean? Well, we knew we needed 8 cc's of PRP, so we started to do the calculations. So we did the calculations with 60 cc's of blood, and we realized that we still were not at that 1.5 billion platelets per cc that we wanted for the injection. So we ended up drawing some extra blood. We drew 90 cc's of blood and processed it down to 8 cc's of PRP. So in his case, we were about 11 times concentration of whole blood, but we were over that 1.5 billion platelets per cc that we wanted. So we can expect him to have a good outcome. But what if we just went with a 30 cc kit like a lot of practices would do? We may have not gotten the same outcome. He may not have gotten better. And this is why I think it's important. If you know you're starting with quality products and you do not get the result that you want, then you've got to look for another reason for the bad outcome. If you don't know whether you've started with a good product or not and you get a bad outcome, the next step can be just starting with better quality materials and doing better PRP. But as long as that variable's not present, we know that we're doing every case the same and starting every case with a high quality, high concentration PRP, then if the outcome is not what we expect, we can look for a reason on why it failed. I hope you find this very interesting. I find the science behind this very exciting. And if you have any questions about today's podcast or a suggestion for a future topic, or maybe would like to be a guest on one of my future podcasts, just drop me an email at realliquidgold@gmail.com. Remember to think as far outside of the box as you feel comfortable, because change never occurs inside the box. And never be passive, always be regenerative. Have a great week, and I look forward to coming back to you in a couple weeks. Bye-bye.